Hello everyone. Sorry about that. Don't know exactly what was going on with Canvas with the recording, so I'm going to record this over and post it for you guys. So we're going to talk about ethics issues that we're having. It's pretty much going to stem over from what we covered the other day in psych. Some terms we will not go back over again because you all should be familiar with them. Just make sure that you know them for the test. All right, so our objective, we're going to talk about the different terminology. We're going to analyze our values and influence approach to ethical issues and decision making because that pretty much drives how we take care of our clients. We're going to discuss about moral implications of the American Nurses Association. We're going to talk about how they help us navigate our Nurse Practice Acts. And we're going to discuss the role in nurses, how we carry ourselves ethically and morally in our healthcare. We're going to identify controversial health issues in healthcare. There are some things that we're going to talk about, and I kind of like want your own opinion about. So we have a discussion board that's going to be put up, and I want you all to talk about that. We're going to agree to disagree. We're not going to be disrespectful to anybody's opinions on how they navigate or think about things. So I just want you guys to be mindful of that. Also, this post will be due on Sunday by noon. And you have to respond to one other person that's in the group. All right. And it's just an open discussion so I can see how everybody's thought process is when it comes to different moral and ethical things and how we maneuver in science during our nursing career. So what are our values? So we talked about the other day about doing our own self-evaluation on what our values and morals are and how we want to carry ourselves as nurses in the future and to be a role model for those that's coming behind us. So we have to choose our values. We have to make sure that nobody bully us to do or the things that they have done in the past. That saying that old nurses eat their young, that back in the day used to be true, but newer nurses are trying not to do that and try to be a role model for newer nurses. Now, with that being said, if you see something that is wrong and you know in your gut feeling that it is wrong, ethically and morally, what you do what the other nurse is doing. So we have to make our own life choices when we're taking care of our clients. So which principle or rule is most important to you as a nurse? Autonomy or non-malfeasance? Well, it kind of needs to be both because we need to allow our patients to have the autonomy that they need in order to help make those decisions to drive their health care. And we need to be able to help them as well without being so much judgmental. But we also have to practice non-malfeasance. That means that we don't want to cause harm to our patients or to the public. So when we take that oath as nurses, that's what we are saying that we're not going to do. We're not going to harm the public. When we get ready to go to state board of nursing, in the next couple of weeks or so that we have on the calendar, you will be surprised of the things that we teach you that these nurses also know, but decided to go another route, either from peer pressure or they already had other underlying issues that end up causing problems. I'm going to find the link to the story of this young lady where these parents had preemie babies and the CPS people and the social worker people was trying to take these babies from the parents because they thought that the parents were abusing these babies because they had broken limbs, and come to find out it was the nurse that worked in that unit that was causing harm to these babies. Now, my daughter was like, this girl went to school all these years to get her license just to lose them. And I said, yes, she not only she's going to lose them, she's going to jail because she could have killed somebody's kid. And that's where I have an issue with, okay? Because you have to know what's right and what's wrong with ethically that you need to do. And they had two nurses that was pulled up in this allegation. One of the nurses was cleared because they did like a timeline of when another baby was in the hospital with these same injuries. And that's how they was able to narrow down which nurse actually did the harm to these babies. When you get put out on administrative leave, that's exactly what it is, administrative leave. And what they're doing is they have to do their investigation to make sure that they have the right person. Now, granted, this nurse that did wrong, she did continue to get paid until they found out that she was guilty of this crime. And so she ended up losing her license. So how do I make an ethical decision? Those are your definitions. It's based on situation. Every patient is different when we're taking care of our clients, and you have to realize that. I may have a patient that came in involuntarily committed, and I have one that came in voluntarily committed, and they both had the same diagnosis. How I handle the one that was involuntary committed is going to be different. How I handle my one that came in on their own admission. So the way I treat them, not so much ethically or morally, but how I treat them in my nursing profession or how I handle them with the situation is going to determine that. I may have to be more stern with the one that came in involuntarily to get them the help that they need versus the one that came in on their own because they know they need the help. The dynamics is going to be a little bit different on how I handle that. So how you handle your patient is going to be different on the situation. But you got to make sure that at all times that you're doing what's best for the patient and what's best for you, because you want to keep yourself safe as well as keeping the patient safe. So how do I determine my own problems? Determine the fact of the situation. After the course of everything, you want to evaluate how I did. The question is, did I handle myself accordingly when I was taking care of the patient that came in involuntarily? Was I too stern with them? Was I not too stern with them? Was I too firm with them or not too firm with them? Or was I more lax with the one that came in voluntarily? Or should I have been a little bit more firmer to make sure that they know that even though they can recognize the symptoms, can they manage them without having to come into the facility? So that's where the evaluating of the outcomes come about when I implement my nursing plan for both of my clients. Did I set out what I want to set out to take care of them? And also you have to incorporate the patient and make sure that they're incorporated in the treatment plan as well, because they have to be willing participants in whatever we do. More in ethical principles, like I told you, the ANA code of ethics. This is something that drives our way of how we take care of our patients. The first of these, it happens back. The code was stated as an outline for the values and concerns for us to be professional nurses. So nurses a long time ago was pretty much practicing on their own autonomy. What they may have thought was professional probably truly wasn't professional. The reason why this code of ethics came out. So the code of ethics for nurses cite the lack of legal enforcement. So we want to make sure that everything we're doing is legally done correctly, that we're legally documenting appropriately, that we're not doing anything that's going to harm us as nurses, harm our fellow nurses, harm our facility that we're working with, and also we don't want to harm the patient. That's the main thing. So the code of ethics is something that we have to know. We believe that students know this and they don't ignore this, that they are more prone to take this into their nursing career and being more vigilant of what's going on in their facilities. Being more vigilant on if certain rules need to be changed in a facility, get on your nurse councils. If it's something that you know that we can make our profession much better, that's the whole purpose of it. We got to make everything better ethically and morally for our patients and for our clients. Then you have your home care bill of rights for our patients. That's something that you need to make yourself familiar with. I'm not going to read that to you. It's in your book so you can read it. So make sure that you know exactly about that. So we come to abortions. So you have a lot of people that want to interject their own opinions on when life actually begins. Does it begin at conception? Does it begin when the baby takes his first breath? We just don't know. And a lot of people like to throw religion into it. And that's something that you as a nurse are going to have to stand firm on. If you know your certain beliefs are what they are, then you may not need to handle these clients, because this baby may be a product of incest. The reason why the mother wants to get an abortion. And if the child is a product of incest, if the child is a product of incest, then the mother knows that she cannot properly take care of this child the way that they need to be taken care of. So therefore, when they decide to have this abortion, they feel like that's the best decision, not only for them, but for their child. Because if they go on and they have this child and they think they may be able to love this child because it is a part of them, when this child gets into this world, something may happen where the child may remind them of their predator. And the child is going to end up being neglected or get harmed or any of those things. Sometimes if they go ahead and decide to go along with it, then they may decide they want to give the child up for adoption. And then you have a lot of people that frown on that. which if they know for a fact in their heart that they don't believe in abortion, that the child does have a right to life, but they can't love that child the way they want and they rather give that child up for adoption, it is okay for them to do that. And we cannot be judgmental on that. Another thing is too, also you have a lot of women that may have had babies and to term, and the baby may be stillborn. If the baby is stillborn and they don't want to go through that trauma of actually have to go through and deliver that baby, especially when they found out in so many weeks that the baby is no longer viable, then they should have that right to have that abortion to get rid of that fetus. And I'm going to tell you why. Because if something is in your body that lies dormant, that is dead, the body doesn't know that that fetus is no longer alive. It considers it as being a threat. So by being a threat to the mother, then the mother is more likely going to lose her life. There are so many doctors now, because of the new abortion laws in different states, that have pretty much gave up their practice because their oath was to not do any harm and to take care of their clients. And when you have government that comes in and tell you if you do these things, they don't matter if the baby is dead or not, the mother still has to go through all of that of delivering the baby, that is torture and trauma for the mother. So there are so many physicians that have gone out and they're no longer practicing because they can't practice to take care of their clients. And that's our, number one goal is to take care of our clients. Next question, it says, should minors have the right to abortion without parental consent or awareness? Once again, depends on what's going on. Was it the parent that is the predator that caused the child to be pregnant? Those are some things you got to kind of like look at. Was it emancipated child? If the child has been emancipated from the parents for so long, that's another thing that's controversial that a lot of people seem to ask themselves. These are the questions that you need to ask yourself when you're taking care of these patients. Are you able to not be judgmental when they have all these things? When you're asking these questions, try to put yourself in their shoes. If they're painting a story for you and telling you about their life, if it was you in that situation, would you be able to have the courage to do what they're doing? How does abortion affect us in nursing? Once again, the code of ethics, it paints out what we should be doing professionally as nurses. And that's something that we need to learn how to do. So the statement in the ANA Code of Ethics outlines our responsibility is number one to the patient. It doesn't matter if it's Peter Pan around the corner, if it's John Blow down the street. It does not matter. Our obligation when we come in and we clock in is to that patient. Now, granted, I'm going to be cordial to my family members that's in the room, but my ultimate goal for the day is to take care of my clients. And some of you that have gone to clinicals with me know that's how I do, and that's how I'm training you to do. We're not being disrespectful to the family, but our ultimate goal is to the family. For example, to the patient. For example, if I have a family member that has come in and they say, Mama needs something for pain. And if I go down into the room and I talk to the patient and I say, well, are you in pain? And if the family's telling me she don't know if she's in pain, the patient kind of like, if she's alerting with it, she knows if she's in pain or not. If my patient tells me that she is not in pain, am I going to get pain medicine? Absolutely not. I don't care about what the family got going on. I know how to assess when my patient is in pain. Some things we've taught y'all to know if your patient is in pain. You look at the vital signs. If their heart rate is up, their blood pressure is up, and it's not long baseline, if they're moaning, grimacing, and groaning, you know if they're in pain or not because their body language is going to be totally different than what they're speaking. So our obligation is always, always to the patient. Do not sacrifice your own values or principle to that you cannot abandon your patient. So if I know for a fact in my heart that I cannot take care of an atheist, am I going to take care of that atheist? Absolutely not, because my heart is not going to be in it, because morally I'm going to be judgmental. Now, over my almost 17 years in the game, I have taken care of plenty of atheists. Their belief systems don't affect me. That's their belief, and I know my belief because I know what I'm standing on. But I'm going to take care of them as a patient. They can talk to me till they're blue in the face about there's no God and this and this and this, and we evolved from plants and animals and the star and the speck in the sky, or whatever it is that they want to say. It does not matter. You have to stand on your own beliefs to be able to take care of the patient. And if you cannot do that to a point where you're upset with your client, then that is not the patient for you. Get somebody else that can do it, because remember, our job is non-malfeasance to cause no harm. Euthanasia. When you look at euthanasia, we're talking about they feel like it's a mercy killing. If you've ever seen anybody that worked in hospice, they have to love it. And then sometimes some nurses get burnt out from it because they have so many of their patients that pass away. Now, they feel like some hospice nurses are practicing mercy killing. They're not practicing mercy killing. They're trying to help the patient have a smooth transition over to the next level of life, which is death. Okay. So the doctors may order their medication in higher doses because we want them to be comfortable. That's why it's called palliative care. Palliative care is to help them to be able to transition without any problems. Okay. They do have the right to die. However, we want to make sure that they have a peaceful transition. You have had some doctors that come in and they'll push it for them. Back in the day, a long time ago, oh, you ready to die? Okay, let me push this and get it over with. You can't do that. You cannot do that. However, you cannot also, you need to watch some of your family members too, because they'll kind of help on with that mercy killing and put the parents on out their miseries. I told y'all about the time when I worked at, right before I came to Baptist, they said it was a daughter that was there. She could no longer take her to mom because the mom was sick with cancer and she was so depressed and out of it that she killed the mom and then she turned around and killed herself. With that being said, you need to make sure that you're paying attention to your family members when you're taking care of your clients. You want to make sure that they're not bringing nothing in to go and put mom and daddy on in the grave because they're tired of whatever it is and they're tired of mom and daddy's suffering. So you need to be paying attention to that also. Durable power of attorney is one of those things where you have your person that's going to make those medical decisions for them when they're no longer able to speak for themselves. I was doing power of attorney for my dad when he was here. I took care of him when he was no longer able to make those decisions. But in the beginning, we both made those decisions together. I talked to him as a role of a nurse and as a role as a daughter. And most of the time it's the role of a nurse because I didn't want to interject my feelings because no person wants to see their parents suffer. So you're going to interject more of your feelings, but I had to be realistic about the disease process that my father had. So I wanted to make sure that when we made all those decisions, it was in the best interest of him and not of me, my sister, or my other siblings or anything like that. It had to be something that he was willing to do. And when it was time for him to transition, I asked him one more time because he made himself a DNI. Before he was full code, he made himself a DNI, and he told me that he wanted us to do everything except for incubate him because we had did that once before, and he said that was the worst feeling that he had ever had because we had to medically sedate him because he had so many clots and stuff in his lungs, and he was fighting against everything to try to get well, so we had to put him in a medical induced state to heal him so he can get some rest. So after we extubated him and everything, he told me he never wanted me to do that again. If it ever came to that was his life choice. And so we made that decision. So when it got to that point, towards the end of his life, I asked him one more time to be on the safe side because he's completely with it. And he told me no, he did not want us to do that, to just let him transition on. And that's exactly what we did. Okay. All right, frugality is the medical intervention beyond the comfort of care without a reasonable hope or benefit to the patient. And then you have your physician assisted suicide, which I kind of like talked about, and that's where the doctor's supposed to do no harm. And there's up on the AMA and ours is ANA, American Nursing Association. There's an American Medical Association. So they have some of the same guideline and guide laws that we have also. All right, next we're going to talk about controversial issues when confronting nurses forced transplantation. So you have a lot of nurses and you have a lot of family members that are against patients that has to have a transplant. You also have an issue with people that want to be donors. So you want to know how are donors solicited. They could be voluntarily solicited, or they can pretty much do it on their own, or if they're a donor or anything like that, a donor. A lot of people said years ago that's like, don't put that donor on your license plate, on your driver's license, or tell people that you're a donor because if there's something happens, they won't save your life. It's a possibility. Can't say 50-50. I don't know. Don't say. But my family knows my issues on what I want to do at my end of life. So my thing is, as long as you have told your family what you want. Some people may not have family that can help them navigate that, to say they want to be a donor. So that's probably why they put it on their license. So when people normally solicited themselves voluntarily, that's because they want to give a life for life. So normally when they come in and they solicit themselves, they have to go through rigorous things things for like medical to make sure they're completely healthy. And the main thing is they have to have the support. I was actually able to talk to one of the guys that actually donated his kidney. And when he donated his kidney, I asked him, what made him do it. And he said, because I'm a Christian and I feel like that I should be able to give life. And so I'm healthy enough. I had the support of my wife or whatever. And so I wanted to donate a kidney. I had to go through all these things to make sure I was healthy, to make sure my kidney was good. And I wanted to donate a kidney. So that's what he did. So once they donate a kidney, they also have to go on anti-rejection medicine as well, because they don't have but one kidney and we have two. All right, so fast forward to that, the patient that ended up getting his kidney was like 2 halls over, and they wanted to know and thank the person, if they was alive, they gave them the kidney. Well, the doctor that did the donor and the doctor that put the kidney in was the same physician. So, of course, you cannot break confidentiality, you cannot break HIPAA, but he did go to the young man that donated the kidney and say, the patient wanted to thank you. I did not tell her that you was here or anything like that. I just want to kind of like put the ball in your court if that's something that you want to do. If it's okay, then I will, set up any kind of arrangements. And he said, yes, but let's do it when I'm about to go, because I feel like I'm going to, I don't want to get too attached to the patient. I want to just do what I need to do. So that's what we did. They set it up right when he was about to leave, and he was able to go around there, and the recipient of the kidney was able to thank the donor of the kidney for giving them another second chance of life. Okay, so let's talk about the ethical issue when it comes to fetal tissue. So fetal tissue is something where most people donate their baby. If they passed away, like they've had like different kind of diseases, and they donate their baby to science, a lot of people frown on that. A lot of religions frown on that, and they feel like, well, God gave you that baby and God took that baby back to heaven. You should bury that baby instead of donating that baby to science. Once again, you cannot interject your feelings onto the parent. They're already having a hard time because they no longer have their child with them. So the only thing we could do as nurses is support them. And if you're not one of those nurses that believe in those things, and these are not the type of clients that you need to be taken care of, because remember, we cannot be judgmental. This is kind of like with the research or the discussion board that we're going to talk about. So we're going to talk about a lady. Her name is Hernetta Lex. And a lot of people don't know, but I'm going to give you the kind of like the story behind it. And this kind of like led to our discussion board. So she was 31 years old. So back in 1951, she was a patient at Johns Hopkins. She came in because she was complaining of vaginal bleeding. Now, back in the day, if you know anything about anything, certain places African Americans just could not go. But Johns Hopkins was the only hospital that would see and treat poor African American women. So once they found out that she had cervical cancer, because that's what she had, Dr. Howard Jones said she had this tumor on her cervix and she needs to be treated. So in the midst of all of that, Dr. Gray, which is one of the labs, they ended up taking a biopsy sample from her. She didn't know they did a biopsy sample because it was something about her that was just different. So they had samples from her, which she's an African American woman, had samples from a Caucasian woman and other people of race. And within 20 to 24 hours, everybody else cells died from that tissue except for hers. It kept replicating. It kept growing. It kept growing after she passed away. And that was kind of odd. And so they was like, all right, so everybody else's cells die, but hers is still replicating. So today they're named HeLa cells. And the HeLa cells are used to help study the effects on different type of toxins, the different type of drugs, the different hormones, the different viruses, and how we need to treat it. So my question that I pose to you, because Ms. Lax tissue helped with science from 1951 to 2025, where we sit right now, do you feel like it was ethically and legal and moral for these doctors to, one, take a sample without her permission from the biopsy, because she didn't know that they was doing a biopsy. They just was been treating her for a cancer. Use our cells in research, not compensate the family or let the family know. Do you think that was legal, ethical, legal, and moral for them to do that? And as you as a nurse, how do you feel about that now? Because we have so many advances in science because of that. If it was you that was the nurse that knew all of this, how would you handle that situation? So that's the question on the discussion board. I want to know what your take is on that. Was it right? Was it moral? Was it ethical? Was it legal? Because we are talking about legal and ethics and our moral duty as our patient. So I want to know what your thought process is on that. In vitro fertilization is another big thing that people have issues with, that legal and morally about. All right, so let's talk about that. I had a client that I took care of. He had his sperm harvest when he found out that he had testicular cancer. And he knew him and his wife wanted to have a baby because they were very, very young. So after we finished his chemo cycle and everything, and we got him in remission and his cancer was cured and everything, because they caught it in the early stages, they end up doing in vitro fertilization. Now, in vitro fertilization is very, very expensive, not only for the mother, but also for the father, especially if they have to take hormonal injections as well. And it can be very draining and very disappointing, especially when you go in and the embryo did not attach to the uterus. That is a loss, and it's considered like a death to the baby, right? So anyway, they end up doing it. Their first in vitro was successful. They had a little girl. And so they was content because it was a possibility that he probably couldn't have kids again because of the type of chemotherapy that we were giving him. Well, 18 months prior to that, when the oldest one turned 18 months, they found out that she was pregnant on their own. They both were surprised. They both were shocked. He mostly was shocked or whatever like that, because he was in disbelief. They went to the doctor and the doctor said yes. They had to watch her very carefully because, we were out, with the chemo and everything like that. But he was like right almost 3 years out from that. So they ended up not having one baby, but two babies. So they had a set of twins, a girl and a boy, and everybody is healthy. Everybody is good. I keep in contact with them all the time. They keep in contact with me because I was the very first one that took care of him through his beginning of his chemo all the way down to the end or whatever. So it's, kind of satisfying when you can see people out in public that you've taken care of, and to know that they've had a good progression with that. Another thing, when you have your designer babies, a lot of people are like, oh, I want my baby to have blue eyes. I want them to have brown hair. I want them to do this and this. And you have people that frown on that. Okay. Also, another thing, a lot of people have an issue when people do in vitro fertilization when they're married to the opposites. They're married to the same sex. Not alone as the heterosexual, but homosexual. So you may have two women that decide they want to have a baby, and they go to the sperm bank and do that. You have a lot of people that frown on that. You have a lot of people that frown on it when you have two men that get married and they want to have a kid, and they may get a surrogate. Sometimes it may be the sperm of one of them, so they know that that's their biological child, but they not so much had sexual intercourse, but did the in vitro to do that with the surrogate. You have a lot of people that frown on that. If you're the type of people that can't take care of those type of patients, this is not the job for you. Because once again, we cannot be judgmental. Everybody's life story is different, and we have to respect that. All right, genetics and genomics. We already know what genetics is. Genetics is just what we're born with. We get so many genetics from our parents, from our mom and our dad, and it makes us be who we are. And that's a role of inheritance. So it tells us about everything that we would need to be for us. Genetics, we're going to have blue, brown, purple eyes, whatever it is. It's going to be based on the genetics of our makeup. Then you have a relative new term, which is called genomics. And this term is used to describe the study of all person genes, including the interaction of those genes with each other and the person's environment. All right, so what is the nurse's role in this area? Our role in this area when we're dealing with genetics is helping with the research and also helping with the treatment. So that's why another thing I want you all to do that discussion board, because I kind of want to know what your thought your thought process is on how research is changing and how we're able to do all these things with the stem cells and especially with the HeLa cells. I really want your opinion on the HeLa cells. So you'll see the discussion board and what I want you to do. And so make sure that we do that because I am interested in your thought processes. All right. How's your ability to diagnose genetic defects? So you have two of them that you normally see. So you have your Tay-Sachs disease. Tay-Sachs disease is normally seen in patients of Asian descent and European descent that live on the South Asian borders of Europe and Asia. You're going to see that Tay-Sachs disease mostly in that demographic of people. Cystic fibrosis, you're going to see it more in your Caucasian people. European descent, and you're going to see, which I don't have on here, which is going to be sickle cell. Sickle cell is normally seen in the African American race. So you have to kind of like know the genetics and what it plays on it, if they're going to be a trait or a carrier of these disease. Now, I'm not for sure if you all gone over Tay-Sachs or cystic fibrosis in your other lectures with the other instructors, but I definitely know that you've gone over sickle cell with Dr. Cox. So make sure that you are familiar with all of that, especially when you're doing your education with your new mothers and everything. Should it be a voluntary or mandatory to detect fetal disorders? I think it could be either way or whatever. I don't think it should be mandatory, but I think if a parent wants to know, especially if they have a strong family history or something, that they should have the right to know and to get this genetic testing. Like my mom, she had breast cancer. She's 25 years out with hers, but I know I have a strong family history of breast cancer because all of her first degree cousins on her dad's side, which is my grandfather, had breast cancer. So my thing is, I want to know why was I HER2 positive? Because if I was HER2 positive, then it was 9 times out of 10 that my girls were going to be too. Even though my mom was negative, HER2 negative, but sometimes it skip a generation. So I opted to have the genetic testing. My insurance did not want to pay for it because they felt like that was something that was on a need to know thing. I disagree on that. If I'm paying my insurance and if I want this test, I think you should be able to pay for it but cancer is a big money laundering thing that's here. There are some things that we can't cure cancer with that's not being done, and that's another reason why they frown on a lot of the genetic testing. With most insurance, they don't want to cover it, and it's very, very expensive. When it's about between $2,500 to $3,500 for this genetic testing. My bill itself was $4,500 because I have a whole lot of things, and I made my insurance pay every bit of it. Every bit of it. They had to pay it because I've been paying in that policy, and I wanted it done because I need to know what I have so I can be able to get my girls tested and my son tested appropriately. All right. Do all individuals merit the same care? They should, morally and ethically, but once again, it's going to be based on the situation, what's going on with your client, on how you're going to handle them. Is the healthcare has a right or a privilege? Healthcare is something that is a right and a privilege. We should be able to take care of them. It is a right for everybody to seek healthcare and get good healthcare based on not because of the skin color, not based on their socioeconomic status, not on because they're married to Peter Pan around the corner, or they're married to the governor, or they're married to the president, or they're married to anybody. Everybody has the right to fair treatment and to the right type of health care. Some people may feel like when older people get older that they don't need to get the type of health care that they deserve. They do. If they're here, if they're walking and they're living and they're breathing, they deserve the same type of health care regardless of age, gender, or anything like that. Uninsured children should be able to get health care. They was brought into this world not by their own omission or anything like that. So why are we punishing them that they can't get the health care because their parents may not have the socioeconomic status to carry the type of policy that their child need if they're sick? So yes, we need to be able to take care of them. And we need to be able to emphasize on preventive care. Preventative care is something that we're going to start off. That's going to be like those vaccines that we talked about. Vaccination, make sure that the kid is vaccinated, make sure our older population is vaccinated to make sure that they don't get the type of diseases that's going to put them in the hospital or put them in the ICU. We need to make sure that our health care is being taught and given appropriately to our clients. Impact of social media. I told you guys yesterday, some of y'all feel like that I can't find y'all on social media. I ain't looking for you for some reason. Y'all are popping up on my feed. Do I know you? It's probably because we may have some mutual friends that you're friends with or whatever. Like I told you guys, we cannot become friends on no social media platform until after you have graduated from the program. However, I do want you guys to go ahead now and start cleaning up your social media. If you have anything on it that's a little raunchy, that's going to keep employers from hiring you, I need you to clean that up. It's very imperative that you clean it up. Even though you feel like, oh, my stuff is set in private, they can't get in it. Lies. They can't. They have tech people that are just for that to be able to get into your account without you even knowing that it's in your account. So if you know you had that account in 2015 when you was 12 years old and you really shouldn't have had that account, and ain't no telling what you put on there, you probably want to go to the very first post when you very first got your account. Clean that stuff up, y'all. I would hate for me to do a little recommendation for y'all because I know some of y'all are excellent students and be excellent in the healthcare, but your social media platform calls you from not getting that job. You cannot post any of your patient's information on social media. You cannot post what type of patient that you have taken care of. Now, granted, I have taken care of clients that have like posted my picture on their social media platform because they asked for permission to take a picture with me. I didn't have a problem with that. They posted and they may have known somebody of somebody and I got tagged. Like one of the ladies that I took care of years ago that worked for one of our news place. I took care of her and she posted my picture of her and some more people on her platform when she was in remission. And my brother-in-law was friends with her and he's like, I saw you on Facebook on such page. I was like, oh, okay. And that was that. And I just left it as that. I was on her page. Also, your hospitals, they may take pictures of you to put on their platform. Now, if you take the picture from their platform and put it on your platform, that's totally fine because that picture belongs to them. Also, do not be in the facility snapping it up in your uniform on the clock. That picture belongs to that hospital because you're in their facility. I don't care if it is on your phone. That picture belongs to them. If you're sitting in the car, you're sitting in the car. You're in the building taking a picture. That picture belongs to that facility. It belongs to XYZ Peter Pan Hospital because you're in your facility on the job, on the clock, with your badge on. That's why I tell you guys when y'all come from clinicals, take your shirts off, take your badges off, throw that crap in your bag. Everybody know you're in nursing school. If you're not in nursing school, it don't matter. Take that stuff off. I have my middle baby. She's in nursing school now. She knows when she hits that parking lot, that badge comes off her clothes and it goes in her bag because she's heard me preach that to y'all so many times that has become second nature to her that she's even told her classmates, y'all, when y'all leave out of class, make sure you take your name badge off. You don't need to have it on because nobody don't need to know that you're in nursing school. Okay? Also, do not put where you work on your platform. Nobody knows that I have ever worked for Baptist. Nobody never knows I've worked for UMC or Methodist or for Homes unless they know me personally on a personal level. I do not put where I work anywhere on it because that is not of a need to know that everybody needs to know, oh my gosh, she started a new job at UMC on the cardiac unit and she's the head nurse. They don't need to know all that. That stuff is for resumes, not for social media. Because you will be surprised people will lie on you and say you've done something when you really hadn't done anything. All right? Do not write or say anything negative about your patients. Oh my God, I had a hard day. Mr. Man and down in 55.5, I want to slap the taste out of his wife's mouth because she did such, and this. Do not put that because it don't take but 2 seconds for somebody to screenshot that and send that to your job. And when you come in and hit that badge and it say, tick, and they say you got to go to HR because your badge is no longer working, you are fired. Okay? If you need to vent verbally out to somebody where it ain't on social media. Do not put that stuff on social media because social media be the death of some of you all in healthcare. Do not harass or use profanity or sexual explicit of anything on your social media platforms. Do not say anything sexual about any kind of patient. Know your boundaries between you and your patient. Do not let your patients follow you on social media. I have one right now. I've been taking care of for years. Every time I see him belt, Alicia, you going to give me your Facebook? Absolutely not. We're setting boundaries. You are my patient. Regardless if I hadn't taken care of you in years, you are still considered one of my patients. If I see you out in public, yes, I'm going to speak. I'm going to be cordial because that's just the human in me. But no, you cannot follow me on social media. I don't want to know what you got going on personally, and you definitely not going to know what I got going on personally. We got to set boundaries, and you need to learn how to do that and do it in a healthy way. All right, using ethical duty, never speak on the behalf of your employer or coworker unless you provide authorization to do so. So that means I'm not going to get on and say, behalf of Holmes Community College, we want to thank the nursing staff at Baptist for allowing us to come and do clinicals on 5D and 6C. You all are excellent nurses. I'm not saying that on behalf of Holmes, unless Holmes has given me permission to do so. And 9 times out of 10, they already have a spokesperson that's going to do that for us. Okay? This is your case study. This is your homework that's also due. It's going to be due on Sunday at noon. I'm going to open up a module for you all to submit your homework. So these are just a case study. And what the case study does is just talking about this patient. Get into the case study if it was you that was actually taking care of the nurse, because you have 6 questions at the end that you need to answer. And I want you to answer these questions truthfully. All right? This is not a group assignment. It's not a group assignment. I need to know, do you know how to take care of this patient? Because if it was me, that's Miss D, can you take care of me appropriately? This is not a group assignment. Once again, I need you to do this on your own. Okay? If you have any questions, all you have to do is reach out to me, and I will see you guys on next week.